Hello, everybody. I welcome you all to this month's CAHO ISQua International Webinar. I am Dr. Anuradha Pichmani, Chairperson of the Quality Professional Wing of CAHO. CAHO, as you all know, is a consortium of accredited healthcare organizations. It is a non-profit organization dedicated to promoting patient safety, quality, and accreditation in healthcare delivery ecosystem. Along with ISQua, CAHO has been conducting this webinar series since January 2021, and it has been very successful. The speaker for today's webinar is Dr. Anthony Staines, Patient Safety Program Director at Federation Hospitals at Switzerland. I welcome you, sir. This webinar will be moderated by Professor Jawahar Pillai, Head of the Department of Hospital Administration and Joint Medical Superintendent at AIIMS Bhubaneswar. I now hand over the session to Dr. Jawahar Pillai and request him to kindly introduce our esteemed speaker. Over to you, sir.
Good afternoon to all from India. It's good afternoon, and many other places it may be good morning and good evening. So namaste from AIIMS Bhubaneswar. This is a very happy moment for all of us. Let me at the outset thank the organizers for giving me the opportunity to moderate this very important session on the team work in healthcare and the TeamSTEPPS. And we have a very renowned speaker, Dr. Anthony Staines. He's a MBA and a PhD in management from University of Lyon, France. And he has authored the work on the impact of hospital quality improvement programs on clinical outcomes. He has been a CEO of hospitals, and currently he is lecturing on quality improvement and patient safety at University of Lyon, France. He is also working with the quality and safety program with the Swiss national report and the healthcare. So we know that hospital, when we consider the hospital as a system, where we have a lot of subsystems like OPDs or ICUs or theaters or laundry or kitchen and etc., laboratory. And there are various professionals, healthcare professionals, like we have security to receptionist to nurse to doctor. So there is a variety of health professionals in the in the health sector, and everyone work towards the single focus as a patient. So the teamwork in hospital is particularly important because hospital is a unique institution where we cannot expect any errors. So it is a error-free environment, and in order to be error-free, the role of teamwork is the most important. And as you know that the steps, the concept which has stemmed from the CRM, that is a Crew Resource Management Protocol by the Agency for Healthcare Research and Quality and the US Department of Defense, which is dealing with the team structure, leadership, situation monitoring, mutual support, and communication. So communication and the teamwork are the most important aspects in the hospital so that we give a efficient and seamless patient care. So we will look forward to the talk from Dr. Anthony. Welcome you, sir, amongst this gathering. And thank you for joining us. Over to Dr. Anthony.
Thank you very much for your kind introduction, and I'm very pleased to be with you today. So perhaps before I start with the slides, let me share with you how our Federation of Hospitals came about to choose to work with TeamSTEPPS. It originated from our work on the WHO safety checklist in our operating rooms. You may remember that in 2008, Atul Gawande and his teams in Boston published the WHO safety checklist proposal for operating rooms, and we introduced that in the following year. And we had a coordinator in every hospital on the introduction of the safety checklist. And after about 5 years of work with the safety checklist, I was the chair of the group of these coordinators, and I asked for feedback from all of the hospitals that had participated. And the feedback was unanimous from the coordinators. They said, you know, I think we've improved in ticking boxes. We are better at making sure there is all of the boxes on the WHO checklist are ticked, but we are not really sure that the improvement in the teamwork that is behind the checklist is really done. So we're sometimes ticking that we've checked the identity of the patient, but it's not a real teamwork check. What should happen is that one person checks the bracelet, the wristband, another person checks the images, the imaging, another person says, I've welcomed this person in the OR, this person said the name was so and so. And with 4 or 5 cross-checking together, that's really a teamwork identity check. And the coordinators were saying, I think we don't have that yet, and we need a method to improve on teamwork to provide more meaning to the WHO safety checklist in our operating rooms. And of course, this method will be useful for many other things at the same time. So that's how we started looking for a method of teamwork. And we looked at different methods, and finally we found TeamSTEPPS, and we were happy with TeamSTEPPS because it's quite easily transferable to staff. We use a one-day training, plus we use coaches to walk people through TeamSTEPPS when they come back from the training to their units, to their wards in the hospitals. So that's the reason why we have selected TeamSTEPPS, which stands for Team Strategies and Tools to Enhance Performance and Patient Safety. And you can see the patient safety movements in the United States with the emergence of medical team training, which was already mentioned in the 2 Areas Human report in 1999, and in the following reports like Crossing the Quality Chasm, there was a huge emphasis on improving teamwork to improve safety. As you can see on the slide, it's in 2005 that the first pilot projects of TeamSTEPPS were set up, and TeamSTEPPS was released to the public in 2006. In Switzerland, it's in 2015 that we have really started promoting TeamSTEPPS in our environment. So in response to the IOM report, 2 Areas Human and Crossing the Quality Chasm, TeamSTEPPS starts by identifying barriers to team performance. So you can see here, I'm sure you're aware of a number of these barriers, like inconsistency in the team membership, lack of time, lack of information sharing. You can see conflict. Of course, conflict, if there is a conflict between, I don't know, anesthesia and surgery, for instance, there is a risk that because of the conflict, people hesitate to share some information. They are avoiding one another. And if information is not shared, it can lead to harm to the patient. So fatigue, workload, distractions, etc., are all barriers to team performance. So what TeamSTEPPS is trying to do is bringing tools to avoid these barriers to team performance. And what you can see here on the introduction slide to TeamSTEPPS is the TeamSTEPPS model. You can see a circle, which is the circle of the team. So one chapter of TeamSTEPPS is about the composition of the team, about the structure of the team. And then there are 4 transferable skills. The first is communication, often structured communications between the team members and the leadership. Leadership, clinical leadership, team leadership is the second transferable skill. Situation monitoring is the third, and mutual support is the fourth. And the idea of TeamSTEPPS is that with the right team applying consistently these 4 transferable skills, you get improved knowledge. That means you get, for instance, a shared mental model within the team of what is to be done. You get improved attitudes like trust, mutual trust within the team. There should be trust like, I don't hesitate to ask my teammates for support, and I don't hesitate to offer my support to my teammates. Often when I offer support, I fear that I will be seen as lazy if I ask for support, and I often fear that I could feel condescending if I offer my support. So if there is sufficient mutual trust in the team, there is a bias towards trust in the team, and then these attitudes improve and the team performance improves. Performance is also one of the results of TeamSTEPPS. More adaptability, more flexibility in the task allocation, for instance, within the team members, more accuracy, more precise information, productivity, things get done a bit quicker, like handoffs and handovers. If they are more structured, if they're more to the point, if they're more relevant, productivity increases. Efficiency can increase as well, and safety, of course, is the aim of TeamSTEPPS. So in TeamSTEPPS, of course, we talk of teams and team members. So we have to define a team, and TeamSTEPPS defines it as 2 or more people who interact dynamically, interdependently, and adaptively towards a common and valued goal. And they have specific roles and functions and have a time-limited membership. So that's what defines a team. And I will show you a video. Don't be surprised, there is no sound for this video, but you will fully understand it without any sound. You see now a train, and you can see a passenger who has put his foot between the platform and the train. And because of that, the train can't leave. And the person is stuck with its foot between the train. And look at what is happening around that person. People are starting to mobilize to help that person. I'll leave you to watch for one more minute. And now the passenger is no longer stuck. Just watch what is happening now. So I invite you to reflect on what you have just seen and to think, was that a team? And if you compare what you have seen to the definition, what you can see is at the beginning, for a short while, it is not a team, it is just a crowd. It is people independent from one another with no common goal. And suddenly, with that passenger stuck, the crowd becomes a team. The common goal appears, and people work along this common goal and interact, and they become a team. So of course, in healthcare, things are more complicated than that. We are a complex business, complex industry. And in our business, we have multi-team systems. So of course, we have the core team. That is the people at the bedside interacting with the patient. And of course, we have contingency teams like medical emergency teams, for instance, that come to help the core team when it is needed. We have coordinating teams, support teams, and we have general management and administration who prepare the ground for teamwork to happen, who define the policies, the strategies, the vision, etc., etc. And all of these teams have to work together towards a common goal. And TeamSTEPPS emphasizes very strongly that the patient is a member of the healthcare team. What we mean by that is the patient has also a role. Things are not just done to the patient, but are done with the patient. It's a sort of co-construction of healthcare together with the patient for the team. So the patient is a member of the team. I invite you now to look at a video from another industry and see how a team is carrying out its duties in Formula One. So you can see that in about 3 seconds, 4 wheels have been changed and gas has been filled, the gas tank has been filled for that car, with everybody knowing what was their role. So you can suppose that there has been a very consistent briefing before, that there is a very consistent debriefing after to learn from what just happened and how it can be improved the next time. And that's teamwork at work. And that's what we aim for in healthcare as well. So I finished now with the module 1, which is teams, and I'm moving into the second, which is communication. So TeamSTEPPS provides tools to improve and to structure communication. The first one is called SBAR, and it's a framework for team members to efficiently communicate information to one another, especially under time constraint when you need a very quick decision from a medical leader or a nurse leader about a patient. So under time constraint, it's important to go straight to the point, but not to leave out key information that is needed for the decision to happen. So SBAR suggests the following 4 steps. Situation, to describe what is going on with the patient. It's it's the title, it's the introduction, it's why you're asking for a decision, why you're calling someone a decision maker on the phone. The second step is to explain the background. The decision maker will need some background and some context to make the right decision. So we should not skip that background. We should include it, but concisely and briefly. Then the assessment. As the initiator of the communication, I would say what I think the problem is. I suspect this or that. And the recommendation would be, for instance, could you come and see this patient in the next 5 minutes? And would you like me to start this and that treatment or exam whilst I'm waiting, for example? I will show you a video that demonstrates these 4 steps, And I invite you to think about situation, background, assessment, and recommendation whilst you watch the video.
Hi, Dr. Feldman? Yes, this is Amy from 2 West. I've been taking care of Miss Everett. Well, she's an 82-year-old woman. She was admitted 3 days ago with DVT. She's on heparin, telemetry, and oxygen. She's been alert and pleasant with no problems other than urinary retention. And she has a Foley in place. But tonight she appeared confused. She's awake and oriented to person, but she thinks that she's at her aunt's house and that Ronald Reagan is president. Yeah, well, no, I checked with her nurse from the last few nights and confirmed that she doesn't sundown and she's normally very sharp. Her heart rate has increased to 110. Her blood pressure is down to 110/60. Yeah, her systolic usually runs 150. Yes. Her temperature is 37 Celsius. She looks pale, but not uncomfortable. Her coag studies are within the parameters, and her blood gas is normal. All other AM labs are normal. She's not putting out much urine, and it looks cloudy to me. I'm worried about her. I think she needs to be seen. You want me to order some labs? Maybe send her urine for culture?
Yes, sounds like she could be getting septic. Send a urinalysis with culture, chemistries, and a CBC. Thanks for calling. I'm on my way, but I need to know if there are any changes immediately.
So you've seen a video that demonstrates the use of SBAR. I don't know how it is in your environment, but what I see around me is that structured communication can be very helpful. When, for instance, at 3 o'clock in the morning, a nurse phones a physician who is on call at home and communication happens, it can be quite challenging. In my environment, there are some differences in culture, in style, in the style of communication of nurses and physicians. For example, nurses tend to be more descriptive, narrative in their way to express things, whereas physicians are much more to the point. And at 3 o'clock in the morning, it can cause some tensions if there is no structured communication. So SBAR has been helpful in our environment.
Hi, Dr.
The second tool of communication is the call out. It's a strategy used to communicate important or critical information where you speak out loud what is happening. So in an airplane, for instance, the pilot could say Mayday, and it draws everybody's attention on the fact there is a crisis. In the operating room, the anesthetist could be saying he's injecting this and that, and everyone is on the same page because everyone has heard what is going on. So the call out is a second tool from TeamSTEPPS. The third tool in communication is called the checkback. The checkback applies the principle of closed loop communication. You may have seen movies. I'm usually quite fascinated by airplane movies where you see air traffic control speaking to the pilots, and every time the pilot would take the message and rephrase the key information that he has received, and air traffic control would check that it is the correct message that has been received, and that's the principle of closed loop communication. So I invite you to watch a video that demonstrates the use of the checkback.
1 gram of calcium gluconate diluted in 100 milliliters of normal saline IV for an hour.
Confirm that 1 gram calcium gluconate diluted in 100 milliliters of normal saline IV over an hour?
Correct.
So that was the checkback.
1 gram of calcium.
The last tool that I wanted to show you in the chapter of communication is the handoff tool. So the handoff is defined as the transfer of information during transitions of care. And it's not only the transfer of information, but it's often also the transfer of the responsibility of the patient. And it includes an opportunity to ask questions, to clarify, to confirm. And there are two possible tools for structured handovers. One is called I Pass the Baton, and a second one offered by TeamSTEPPS, it's called IPass. Here in Switzerland, we have selected IPass. It's a 5-step tool that starts with describing illness severity. That's at the very beginning. The first step of IPass is illness severity. IPass suggests to categorize the patients between stable, unstable, or in between a watcher. And that allows the person who is handed the patient over to know immediately in case it is an unstable patient and to pay more attention to the situation of that patient. The second step is to summarize what's going on with the patient. The hospital course, the events leading to admission, the treatment plan for that patient. The third step is the action list, the to-do list. What have I not been able to do in my shift, and what is expected from the people taking over the next shift to carry out? The to-do list with the timeline and who's responsible to do what. The action list is a sort of list looking back at the past, what hasn't been done and should be done in the future. And the S for situation awareness is a look of anticipation into the future. Know what's going on about the patient and plan for contingencies. If the laboratory results come back positive, then the physician has asked to be informed within the next 5 minutes, for instance. The if then is the contingency planning. And the last step of IPass is the rephrasing, the synthesis by the receiver. And that covers at least the key actions that are to be done in the next shift. And it's an opportunity also to clarify and to ask questions. I've finished with the second chapter of TeamSTEPPS. The first was team composition and structure. The second was communication. I'm moving into leadership. And TeamSTEPPS distinguishes between two types of leaders: designated leaders and situational leaders. So a designated leader would be, for instance, the chief physician for a ward or the chief nurse for a ward, and that's a long-term position, and that's a designated leader. The situational leader would be the first one to come to help a patient that is experiencing a stroke or a cardiac arrest, and that person is just a qualified professional but has no hierarchical authority over the rest of the team. But this person is the first on the spot and is taking leadership and will brief the next people to arrive and will assign tasks and roles to the next people to arrive. So effective team leaders, what you see here from TeamSTEPPS, can apply both to situational leadership or to designated leaders. Defining, assigning, monitoring a plan, for instance, can be the plan for the work in the ward for the next year, and that's for designated leaders, or it can be the plan, the tasks, etc., for the next 5 minutes to resuscitate the patient experiencing cardiac arrest, for instance. And all of the next lines on this slide can apply both to designated leaders or to situational leaders. So TeamSTEPPS talks of leadership mainly in the case of situational leaders and offers 3 tools. The first is called the brief. So a team briefing is an effective strategy to share the plan, to form the team, to build up the team, to allocate tasks and responsibilities, to establish a safety climate and goals for the team, and to engage in short or long-term planning. So starting the intervention or starting the day in the ward with a brief can be very important. You will see a video that demonstrates the use of the brief.
Okay, she currently only has intermittent late decelerations, and these have improved with her position changes and supplemental oxygen. We'll monitor her until she's fully dilated and allow her to push. If there's any evidence of fetal distress or persistent late decelerations, we should be prepared to go to C-section.
I've alerted the OR to be prepared in case we need to use it.
Great. I'll discuss this plan with Mrs. Keys when we're done here. What are her vitals right now?
Normal, just checked 15 minutes ago.
She's had no late deceleration since you recall.
Let's continue to monitor her. I need to know when she's complete and pushing so we can keep a close eye on her second stage. Any questions?
So as you can see, the brief is a way for the team to be on the same page. Both on the same page in terms of content, the tasks, what should be done, but also in terms of climate, sharing information, building a safety climate where people are free to speak up. The second tool that I wanted to share in leadership is called the huddle. So perhaps in the morning, the team got together and had a briefing and allocated tasks and defined a plan. Perhaps later in the day, some people have called in sick and the number of people on the ward is not the same as it was planned, or perhaps there's been a difficult situation with a couple of patients, and because of that, the plan needs to evolve. And so the huddle is a very short ad hoc meeting, a touch-based meeting to regain situation awareness, to be all on the same page of the new situation, to discuss critical issues and to reassign resources and tasks within the team. And the last of the 3 tools in leadership is called the debrief. And the main purpose of the debrief is to learn about what went well and what should we replicate the next time we come across the same kind of situation, and what did not really go well and could be improved for the next time. So it's learning, it's team learning about events that have just happened. That's the debrief. Here is a video.
Great job, everyone. Can we discuss how things went today with Mrs. Keys? What did we do well, and what can we do better next time?
It was helpful for me to be brought in early. That allowed me to use a regional instead of a general anesthesia.
You're right, Grant. Lynn, what did you think?
It was great that Dr. Dean helped put the Foley in place while I did the count with Alicia.
Albert, this is a great example of task assistance. How was our communication today?
Excellent.
As you can see, learning in the team is the debrief.
Great job.
And so I'm moving to the 4th chapter of TeamSTEPPS, which is situation monitoring. I don't know if it has happened to you. It has happened in my environment that we were very busy looking after a patient, resuscitating a patient, and not noticing that very close by there was another patient who needed our attention more. But people in the team did not understand the evolving situation, did not understand that we were preoccupied and busy with a crisis, but there was an even more important crisis emerging next to us and which we did not notice. So situation monitoring is firstly an individual skill to screen the environment and to try to notice what is emerging in terms of the situation in my environment. And if that is well carried out, it brings situation awareness. It's an individual outcome in which I understand how the situation has evolved and where I should focus my priorities. It's not still yet sufficient, and what I need to do is alert my colleagues and as a team build team situation awareness, which is called a shared mental model and which is a team outcome. So let me show you a video with a situation outside of healthcare where the shared mental model does not happen, and let's see what happens. Sorry that I'm using a commercial. Sorry that I'm using a commercial for this, but I think it's easy to understand the misunderstanding that is happening here and the absence of a shared mental model with a car driver who is running and then stretching on his car, and a lorry driver who thinks the person wants to push his car over the cliff and helps him to do so. So to gain situation monitoring, TeamSTEPPS suggests a model made out of 4 steps. The first step is, so all of this is part of screening your environment to gain understanding of the situation. So the first thing we will look at in terms of screening the environment is the status of the patient. The second step is to look at the team members, team fatigue, stress, etc. The environment comes next, the equipment, for instance, and then progress towards the goal. So if I take an example of this, suppose I'm a ward leader and I'm walking in the corridor in my ward in a hospital, and I see there is a door that is empty, sorry, a door that is open, and I can see a patient, and the patient looks very pale. And I'm a bit bothered by what I see. The second thing that I look at, that's the status of the patient. The patient is pale. Then I look, is there someone around looking after this patient? And I can see no team member, no nurse around this patient. That's for team members. The environment, I can see a perfusion that is attached to this patient, but the perfusion is empty. And so I go and look for the nurse in charge of that patient and draw his or her attention to this situation. So this is an example of situation monitoring, understanding how the situation is evolving. The second section of sorry, I'm moving to the 4th chapter of TeamSTEPPS, which is mutual support. So in mutual support, we look at people assisting each other, providing and receiving feedback, and exerting assertive advocacy behaviors in favor of the patient. So task assistance happens when team members foster a climate in which it is expected that assistance will be actively sought and offered. it means creating the right climate so that I can trust that if I offer my support, I will not be seen as condescending, or if I ask for support, I will not be seen as lazy, because it will be interpreted in the context of helping the patient and patient safety. That's the climate of trust in which task assistance can happen. And it can be created in the briefing, for instance, with the team. Then I mentioned that feedback is very important, and high-performing teams use a lot of feedback towards one another and help one another with providing feedback. Effective feedback is timely, respectful, specific, directed towards improvement and not on blaming people, and it is considerate. So another important thing I mentioned about advocacy in favor of patient safety, in favor of the patient. I don't know if it has happened to you. I have seen in my environment a situation where a very junior physician was helping in the OR, assisting, and the person operating was the boss of the boss of the boss of his boss. And suddenly the junior physician notices that the incision is happening not on the side that was mentioned on the operating program. So what happens in your environment in such a situation? I don't know, but I can tell you what is happening in my environment. Too often still, the junior physician hesitates to speak up and to mention that there is a problem. And that is something very crucial for patient safety. And so TeamSTEPPS provides a tool to make sure that there is an expectation that people will speak up, but that they will speak up respectfully and concisely. And so the tool that is proposed for that is called the CAHO. It's keywords saying, starting with "I'm concerned," and if that is not sufficient, escalating to "I'm uncomfortable," and if that is still insufficient, escalating to "this is a safety issue." And it is expected that the other person to which this CAHO is addressed, when they hear the word "concerned," they will stop, pause, and listen to the safety concern, or stop at "uncomfortable" if they didn't get it at "concerned." And if it's still insufficient after the 3 steps, it means going further up in the hierarchy to seek help. Let's watch a movie with this used.
Dr. Dean, I'm concerned about Ms. Keys. I'm uncomfortable watching these late decelerations. The baby's heart rate's in the 60s. I mean, I just don't think it's safe to continue labor.
So you can see the keywords used. So it's a sort of code word to draw attention to a safety concern. Okay, so what we have just seen with the CAHO is a tool to resolve conflict about information. Different people have different information, and they use the CAHO to align their interpretation of the information. There is another type of conflict that can happen in healthcare, which is interpersonal conflict. And there, the tool that is suggested is the desk script, which is a constructive approach to manage and resolve conflict, to de-escalate conflict, to make things less emotional and more objective. And so it's a structured way to do that by describing the specific situation, expressing your concerns about the action, suggesting alternatives, and then consequences should be stated if we don't find a solution, what is going to happen. so a way to de-escalate conflict. And that was the last of the TeamSTEPPS tools that I wanted to show you. So if I summarize the content of TeamSTEPPS, TeamSTEPPS identifies barriers to teamwork. TeamSTEPPS identifies goals of teamwork, outcomes that are sought, especially patient safety, but also trust, team orientation, a shared mental model, etc. And the way to go from the red to the green is by using tools and strategies from TeamSTEPPS: communication, leadership, monitoring, and mutual assistance. I've not been able to show you every single tool in TeamSTEPPS in this short presentation, but I believe you have seen most, something like 80 to 90% of this. And so the philosophy of TeamSTEPPS is to apply this with the model from John Kutcher about the steps of change, and to walk through until you create a new culture in which these tools are used. So TeamSTEPPS suggests a change model where you do an assessment of your culture, of your incident reports, of your climate, etc. Draw an action plan, use TeamSTEPPS to improve through training, through coaching, through continuous improvement techniques. And coaching has been for us a very important step. TeamSTEPPS is not just about providing training, because in our environment, people undergoing training are very satisfied with the training, but they do not start using the tools the next day. They need to find champions, peers, coaches in their environment who help them acquire, reinforce, and use the skills that have been taught to them. And so it's important in deploying TeamSTEPPS to follow an institutional implementation plan to set it up. Lastly, does it have impact? Well, there is an emerging literature about the impact of TeamSTEPPS. We have done one contribution in our environment, which is to measure the impact of the deployment of TeamSTEPPS on patient safety culture. And we have had the privilege to have one hospital that had 2 maternity wards, and we deployed TeamSTEPPS in one of the maternity wards and not in the other. And we measured safety culture before and after in both wards, in the intervention ward and in the control ward. And what you can see here is the change of patient safety culture in the intervention ward. When it's green, it's an improvement. And when it's red, it's a decrease in culture. And this is the control ward. And you can see that there is a substantial difference. It's statistically significant on 3 of the dimensions within the 12 dimensions of safety climate proposed by AHRQ. I have finished now my presentation, and I'm ready to take questions if you wish.
Thank you, Dr. Anthony, for a lucid presentation with a lot of illustrating videos. I think our participants would have certainly enjoyed listening to your talk. Thank you very much for this session. They fail the teamwork, and how do you manage the situations?
Okay.
Yeah.
So if someone in the team failed the teamwork, I think one thing is the instrument that is called feedback. It's important that the colleagues provide feedback to that member of the team and remind the team member of the expectations, of what can be done, etc. Then there is another issue, which is leadership. I think in the initial brief and in the debrief at the end of the shift, it's important that situation where there have been mishaps of teamwork, that the leaders comes back on that and that there is learning that happens within the team on how better to use teamwork. That I would use, and feedback within mutual support is another one that I would use in such a case.
Now here there is a clarity we would expect is that there are two models where you discipline somebody with some kind of memos or actions, disciplinary actions against them, and there is another model where you boost up the morale, you counsel them, and then you motivate them to become the member. So, what is your view on that?
Well, I'm in favor of what I call the just culture, and what I mean by the just culture is that we should not too quickly use blame and sanctions, disciplinary actions, but it still is allowed to happen. But we should distinguish between the cases. So we should analyze the situation, whether it is a system failure, and that is something that is, in my experience, the most frequent case. It is a system failure, and the healthcare professional is a sort of hostage of a system that is failing, and the co-worker, the worker, should not be blamed for the system that is failing. And so we should support the people and try not to blame and not to use disciplinary action. But some situations, they are more rare, they don't come about so often, but it can happen that someone takes unwanted risks for the patient, does not use the best available science, or even intentionally harms the patient. So, for instance, for intentional harm, there should be disciplinary action. So I'm not saying never any disciplinary action, but I'm saying caution not to discipline someone when the person is not responsible and when in fact it is the system that is not ideal.
Thank you. The second question people have asked is about the change management. As we know that whenever we implement anything new, always there is a resistance to change. So what are your views on that?
Yes, it happens to me all the time in my environment. People are often not very comfortable with changing. Lots of people want change, but they mean they want others to change, and they don't want change to apply to themselves. So I can understand this question and this remark. Now, I have found that the 8-step model from TeamSTEPPS that you will find on the slides is very helpful and very useful. So I use that quite a lot. The first step is to create a system, a sense of urgency. Kotter uses the image of create a burning platform. You can imagine a gas platform, a petroleum platform that is burning. There is no choice to change. So to motivate people to change, you should show what cannot continue to happen the way it's happening, and what are the consequences if things continue to happen. It can be harm in patient safety, for instance. We show the harm, we have data about the harm, etc., and people understand that there is a need to change. And then you build a guiding team, a multidisciplinary team that takes leadership, that creates a vision, and people will not change if they're not attracted towards a new vision of how things should be, a harm-free environment, for instance, and that is a vision. And then we need to empower people to help them find what can be their own and specific contribution to that plan. And finally, all this enters a new culture. And you have won the deal when it's no longer you as project manager insisting that people change, but when it's the whole environment around them, the culture that persuades them that they should change. That's my experience, but it's difficult.
Thank you very much. So the next one, the issue is with regard to the multidisciplinary teams. So we know that there's a healthcare team. We have a clinician, we have an anesthetist, we have a nurse, and people from various walks of life. So people have their own egos, and how to bring this group together and who will lead the team, whether the senior person in the group will lead or any junior person who is coming new can also lead the team. Is there any thoughts from your side?
Well, in my view, this is where there is a distinction in TeamSTEPPS between the designated leader and the situational leader. So what I mean by that is the long-term issues are dealt with by the designated leader. It's the ward manager, it's the chief physician, it's a senior person that is the designated leader. But there can be situational leaders, like there is a cardiac arrest, we need to resuscitate the patient. We're not waiting for the big boss to arrive to start the resuscitation. It's the first person on the spot. It's any qualified professional. It may not be just someone in training, but all of the others that have undergone training, that are qualified, can take this leadership role for this situation. But it means they also have to have the leadership tools that are the briefing, the debriefing, the huddle, etc. They need to understand these tools, and it's not just the ward manager that needs these tools. It's everyone, every qualified professional. But that person's responsibility as a situational leader will end within perhaps 15 minutes. And after 15 minutes, he is no longer a leader, or she is no longer a leader. It's again the designated leader who will take over.
Thank you for that. One more, the last question. If you agree, it's about the monitoring. Now, if the team is performing, and is there a need for a separate team for monitoring, or the same team, some of the members can monitor? How do you audit, or how do you monitor? Is there any separate team for monitoring? Is it required?
When we talk of monitoring in the team in TeamSTEPPS, it implies gaining situational awareness. It's in this context that situation monitoring is used. And TeamSTEPPS recommends that this should be a skill that should apply to every professional in the team. We should all contribute to situation monitoring. And once we understand that something has changed in the situation, it's the role of the leader to draw all the new information about how the situation has evolved and help facilitate the decision making. But every team member should be responsible for gaining information about team monitoring.
Thank you very much, Dr. Anthony. It was a great evening with you, and I hope the participants would have certainly enjoyed this session, and also for sparing your time for this question answer session. Thank you very much. Over to the organizers. Thank you very much.
Thank you, Dr. Jawahar, for doing a wonderful moderation of this session. And I would like to thank Dr. Anthony Staines for taking the time to share your experience and expertise with all of us today. It was very nice to listen to your concept of TeamSTEPPS, considering that the teamwork is critical to raise quality and patient safety in healthcare. And specifically, it was an excellent presentation with brilliant examples, and you have proved yourself that you're a great teacher. And all of us enjoyed the various videos, especially the Ferrari video, with good teamwork. And as a token of appreciation, we would like to present you with a certificate. And I would request Dr. Vijay Agarwal, President CAHO, to do the honors.
It's my proud privilege to present the certificate to Dr. Anthony Staines. Thank you very much, sir, for your wonderful presentation. We have all learned a lot. Important thing is to put them into practice. So thank you, and please accept this token of our appreciation as a certificate to you. Thank you so much, sir.
I very much appreciate that. It's been an honor to be with you. Thank you very much for inviting me. And thank you very much for this interest. I was impressed by the participation, seeing how many people attended. It shows a lot of interest. And I think you will be on a wonderful track of teamwork. Thank you.
Thank
we
you,
look
sir.
forward for your continued patronage. And we had participants from more than 20 countries participating in this webinar. So thank you, everyone.